Takes a lot of effort. All right. Welcome to everybody for being here today. I am Debbie Gray, the Associate Dean for Harris College of Nursing and Health Science in the Research and Student Issues side of Health Sciences. This symposium has been going on now for, I think, 9 years, which is good. For those of you that come regularly, you probably realize that we are seeing more and more people come to these in attendance. I think our average attendance this year has been somewhere in the 35 to 40 range. When we first started, if I could get 5 or 6 there, I'm serious. It was like, oh my gosh. But anyway, we've come a long way, and I'm glad you're all here today. With that said, this is our last one for the series for this year, and we're going out on a big bang. Dr. Melody Phillips is here to present for us today on immune function and some projects that she's been doing in the field for quite a while now. So I'm going to go ahead and turn the floor over to her. She's from kinesiology. Thank you.
So Debbie called me this morning and made me wear this shirt.
We want to be together.
Yes.
Yeah.
First, thanks everybody for being here, particularly my colleagues first, because I know how hard it is to get away for events on campus from the office and teaching and research, particularly during advising season. So thank you. And I can neither confirm or deny the presence of current or previous participants due to HIPAA and privacy laws. However, if you are one of those, welcome. Okay, so I changed the title just a little bit to target somewhat better what I'm going to share with you today. We have been working on a series of projects here at TCU that have led up to the current project for which we are collecting data. We currently have many subjects enrolled, and I will share that with you. Prior to then, I'm going to give you some background and share some data with you. So the objectives for today, certainly the background. I want to link immune function and heart disease. For many of us who would think the immune system affects our cardiovascular system, well, know now, every system in the body affects every other system in the body, pretty much. So there you go. You learned it all. That's how it works. Particularly, I study inflammation. We all know exercise is good for you, but we still don't know exactly how it works. We've learned many wonderful benefits that consistent exercise confers, but still we don't know all the cellular and molecular mechanisms by which those improvements occur. Inflammation, we hear that word and we generally think it's a bad thing. It's not. Inflammation is absolutely key to proper healing and recovery. However, it's when a low-level systemic inflammation develops that it is related then and propagates inactivity-related diseases, inflammatory-related or inactivity-related, such as osteoporosis, type 2 diabetes, type 1 as well, in some little different way, and of course heart disease, cardiovascular disease. Okay, there are numerous markers in the blood, on cells, that tell us the body may be in an inflammatory state or one cell may be activated rather than another. There are many different dissolved proteins in blood that communicate among all the cells, immune cells, as well as our tissue cells. Many of them are called cytokines, and there's a gazillion of them. I'm going to introduce a couple to you that we generally measure. Another is C-reactive protein. That's actually used as a clinical marker today of inflammation, and I'll give you a little more detail on that. So the two specific types of cells we're working on now, one is actually a complex. It's called a platelet monocyte complex. It's a white blood cell with platelets stuck to it. I'll explain it more in detail. The other is a certain type of T cell, another one of our circulating leukocytes or white blood cells. And in fact, it appears that T helper 17 cells, they're an inflammatory type of T cell, many different T cells. It may promote hypertension. Yep, hypertension may be an autoimmune disease. You knew, right? I know. Okay, so I'm going to share some previous data, and I'll be talking a lot about these cells that we move through. So I have to thank Dr. Dennis Cheek. I stole this little cartoon from him years ago. It identifies the 5 major symptoms of inflammation, and certainly if you break your leg, you get an infection, a cut, you can appreciate heat, redness, swelling, pain, and loss of function. But when inflammation occurs inside the body, you can't necessarily see it or feel it or observe it. Okay? So it's hard to detect. Again, there's a whole list of what may be called, I said inactivity-related diseases. That's accurate. Sometimes we call them age-related diseases because you see more osteoporosis, Alzheimer's, of course, as we age. But we know that exercise has some control over either lessening the risk or attenuating the severity of many of those diseases. So that means it's not always just age-related, but maybe sedentarism, is that a word? All right, so I want to point out something here because we measure many of these markers that are telltale signs of a condition known as the metabolic syndrome. Okay, you are diagnosed with the metabolic syndrome if you have 3 or more of these specific factors related to the metabolic syndrome. Hypertension, that includes if you're being treated with a drug. Insulin resistance, plus or minus glucose intolerance, that means you have pre-diabetes or full-on diabetes, of course. Generally, it can be measured with a fasting blood sugar or blood glucose of 100 milligrams per deciliter. Dyslipidemia, that means high lipid or cholesterol in the blood. If you have high lipids or low HDL, that's the good cholesterol, either of those can be a risk factor. Certainly obesity, particularly central obesity, but obesity in general is a risk factor. And now, many organizations are including this pro-inflammatory or pro-thrombotic state. That means you have this low-level systemic inflammation, which is generally associated with cardiovascular disease or other diseases mentioned above. So we measure many of these things. In the current study we're doing, we're not getting insulin resistance, but we are going to measure insulin and glucose and have those values to compare to all of our others. So we're measuring blood pressure, we're getting lipids, certainly we're measuring body mass index and getting percent body fat using the DEXA, and we're measuring numerous chemicals in the blood. Now, in 2004, so 14 years ago, I believe this was the first lay publication that introduced inflammation as associated with heart attacks, cancer, Alzheimer's, these different diseases. About, 5 years before that, Dr. Ross compiled a lot of information from previous studies in the 80s and 90s. And he declared at that time, writing in a review article, that atherosclerosis is an inflammatory disease. This is from years and years of work. And I'll show you in a moment a cartoon that helps to explain what that means. Now, this is a flow chart. You can make a number of different flow charts using various inflammatory markers. But I wanted to point out, this starts with adiposity because I am interested in a group known as Fat But Fit. That's a thing, Fat But Fit. And it tells us that even though you may be overweight, if you're exercising regularly, you're enjoying the benefits of cardioprotection from that exercise with or without losing weight. Would you be better off if you lost the extra weight? Sure. But it means if you're exercising and you're not seeing weight come off, it doesn't mean stop exercising. And I have data reported in a study which I'll present. But in any case, adiposity also promotes inflammation in the body. In fact, our adipocytes, our fat cells, actually release inflammatory chemicals. And the more fat you have, the more they release. Here's an example of the increased adiposity. Increases the pro-inflammatory milieu of the body. That's just all the stuff circling around, right? I'm going to point out a couple of chemicals, cytokines that I measure, and you'll see them again. Interleukin-6, tumor necrosis factor alpha, adipocytes increase production of those pro-inflammatory cytokines, and there's that C-reactive protein again. We'll talk about it, but those are some things I've measured. I've measured others, but in any case, high levels of those interacting with the endothelium, the inside of your blood vessels, increases a problem known as endothelial dysfunction. That means your arteries don't respond appropriately to changes in blood pressure or to they don't dilate well. It increases insulin resistance. Both of those certainly promote atherosclerosis. And of course that causes heart attacks, right? So there's a lot going on, not just the immune system. Adipocytes are literally, it's a type of endocrine organ now. It releases lots of different molecules. Some you would say good, some bad. They all play a positive role in regulating the body. But when you have a system that is somewhat perturbed and not working correctly, it can certainly promote disease. Here's the cartoon I mentioned. Take a look. Here's the heart, obviously, and they've taken a cross-section of one of the coronary arteries there, arterial. Okay, it's got smooth muscle that allows it to dilate or constrict, depending on the blood flow needs of the heart. And the endothelium is this inner layer of cells. It's very active. It can produce a lot of chemicals to help dilate or constrict the heart. And of course, here's our blood traveling through. Okay, so if you have hypertension and you don't reduce the hypertension, or you have high cholesterol and you can't reduce the circulating bad cholesterol or triglycerides, that damages our arteries. If you just think, literally, the high blood pressure of hypertension, that's hydrostatic pressure pounding on the artery walls. It causes shear stress, and over time it can actually damage. Of course, high fats, they actually can invaginate, so to speak, get embedded in the artery wall, and our immune cells try to clean them up. But if you don't remove the stressor, whether it's hypertension or the high cholesterol or whatever it is, the arteries are unable to heal. The immune system cells, they come rolling along, and this is part of the, I guess it's, let's say it's right about this part of this artery. You see all the yellow dots, it's supposed to be lipid or cholesterol. These are our monocytes. They're getting called into this area to help chew up, clean up, get rid of some of those lipids, or let's say the endothelium is damaged from the hypertension. They're trying, that's what our immune cells do, they heal us, right? They're trying to heal. Well, what occurs if you don't stop the insult? These monocytes become larger cells, macrophages, that try to chew up and dispose of that cell debris and the lipids. And it's a futile cycle. They become what are called these big foam cells, which are just filled with cell debris, lipids. They're releasing a lot of inflammatory cytokines to help speed up the immune response, to heal it. You get the point. It's a vicious cycle, so to speak. Well, the plaque builds up on the inside of the artery. I guess it could completely close it off, but here we see where the fibrous cap has burst and blood has leaked out, it's bleeding, and that formed a clot. That's a heart attack, right? So our immune cells are very active in atherosclerosis. It's a failed healing attempt, you might think of. So here we see our monocytes. That's one of the cells we're examining currently. And here, I believe these are some T cells. Our T helper cells are involved as well. All right, so real quickly so that you understand what's happened. We're measuring or looking at changes in monocytes in the blood, but the monocyte is the cell, one of the cells that invaginate into the endothelium. They differentiate into macrophages. They become so engulfed, or they engulf so much debris, they become foam cells, causing plaque formation and even more inflammatory cytokine secretion. So there's the vicious cycle. Some more cytokines. There's our tumor necrosis factor alpha, IL-6, and another IL-1 beta, interleukin-1 beta. Again, classic pro-inflammatory cytokines that promote an inflammatory milieu in the body. So monocytes are key players here, but so are our T helper 17 cells. Okay, so now that you have that background, you have a good idea there. I want to show you data that agrees with mounds of other data that consistent exercise does reduce this low-level systemic inflammation in individuals who are suffering. Again, two of these really classic pro-inflammatory cytokines that can be an indicator of systemic inflammation: tumor necrosis factor alpha and IL-1 beta. So I did a project. Let's see. This was ladies aged 65 to 85, average weight. They did a 10-week resistance training study. They came in 3 times a week, did 10 different resistance exercise training machines, and before and after we examined circulating pro-inflammatory molecules. So the first one was interleukin-1 beta. Now, the blue, green, and red, those are all part of the exercise group. We just divided them up based on whether they were on hormone replacement therapy, no hormone, or Evista, a selective estrogen receptor. Don't worry, all of these are our exercise group. We had one control group. They were all no hormone replacement therapy. So we got a blood sample before and after the training, and this shows IL-1 beta in 1/3 of the exercise group, another third, and the other third. So we see a significant decline here in IL-1 beta circulating in the blood versus the control group. There was no change. It looks like it trends up a little, but there was no change. So we can fairly confidently say that exercise resulted in a reduction in that inflammatory cytokine. That's a good sign. We also measured resting TNF-alpha, basically the same result. I won't take time to go over it, but this was one of the first times anybody had used strictly resistance training as opposed to aerobic training to examine inflammation, low-level systemic inflammation. And again, in older ladies, I can't stress how important resistance training is for ladies, particularly as we get older. We use our upper bodies less. We don't have as much to start with as men. So I wanted to incorporate resistance exercise into the study of heart disease or these other diseases. Because everybody was using aerobic training. You know, that's what you think, go for a jog or a walk. But okay, so that brings us to the first training study at TCU. It's the LOL study. The ladies name themselves the little old ladies. That's not my terminology, but they name themselves that. So this time they did 12 weeks of the same protocol, resistance training only. And rather than just control participants, we actually had an education group that came in twice per week for education sessions. That's really important, and if you're a scientist, you know how important it is to control for certain things like, well, certainly diurnal fluctuations potentially, if that affects, seasonal fluctuations, and even social interaction and the very act of learning more about your body or about health. So we had them come in. Here's our 2 groups: exercise, this is how old they were, education, BMI. So that explains a little bit about the population. Now, before we go further, I do want to show you a little more about the C-reactive protein. I mentioned it is used now as an indicator of risk for cardiovascular disease. And we can measure in the blood. The units are milligram per liter. And based on the data we have now. If your CRP is less than 1, you have a relatively low risk of cardiovascular disease. If your CRP is 1.1 to 2.9, a relatively moderate risk, and of course, if your value is 3 or above, you have a high risk. That's all. Those numbers are always taken into consideration with other risk factors, but these are clinical marks, clinical measures. So anyway, for this particular study, we measured, actually what started this is I was really interested in what's happening in the fat tissue in response to these kind of training studies where you see reductions in blood variables that could be considered, associated with disease. And so I wanted to get some fat and see what's going on there. So we took fat biopsies before and after the 12 weeks of training, and we examined messenger RNA expression for several inflammatory markers, and we found no change. So, I was like this, darn, it didn't help. No good. Quit exercising. It's not working. But what we did find is that in our exercise group, these are the exercise, this is the control group, or education, I should have. This light bar is before training, after training, before training, after training. Notice that in the exercise group, CRP declined significantly by 33% after the exercise training. That's a huge decline. In fact, that group, they were in the moderate risk level, and it moved them down to the low risk level. Clinically speaking, that's important. And the TNF-alpha, again, it's a pro-inflammatory marker. It's not used clinically. There's a lot more variation, but it's a major pro-inflammatory cytokine. It was reduced by 29% by the exercise protocol. So these are very, very positive alterations in blood inflammatory markers. So we found, I mentioned a moment ago that many studies up to this point, the authors used aerobic training as a type of exercise intervention, and many of them failed to detect a CRP reduction without a decrease in fat mass. They had to have a reduction in fat mass if CRP was reduced. Well, we didn't. We found a reduction in CRP. We found a reduction in CRP with no change in fat mass. Again, I was disappointed. The fat didn't change. It wasn't less inflammatory, at least as measured. Maybe it wasn't that inflammatory to begin with. But it shows, number one, at least for these subjects in this particular study, that exercise is good for you, so to put it simply, without observing benefits like a reduction in weight. Okay? So keep exercising even if you're not losing weight. You are experiencing wonderful cardioprotective benefits. So during this time, this cell aggregate came to my attention. We all, of course, monocytes are one of our white blood cells. We have them all circulating. And sometimes when they are activated, platelets will stick to them. And platelets are, of course, the cell fragment responsible for blood clotting. Right? When you cut yourself, you don't want to keep bleeding. You want it to clot, heal. So, of course, our platelets circulate. And clotting, not clotting, is regulated very tightly. But again, in these low-level systemic environments, that environment can activate our monocytes, even our platelets. So monocytes will fairly readily stick to the platelets, or rather the platelets stick to the monocytes, either way you look at it. And that makes them very sticky, meaning they adhere to the interior of your arterial walls more readily than if you had fewer of them. We all have circulating platelet monocyte complexes in us right now. Most of our more healthy folks, maybe 8%, 10%, 12%, maybe 14%, 15%. As you move up 20%, we're getting into ranges where obesity may be contributing, cardiovascular disease, and way up in full-on diabetics, we could see as much as 50% of the monocytes having these platelets stuck to them. Okay, so they're highly related to, this is just from one study. These platelet monocyte complexes were highly correlated to the extent of aortic and femoral atherosclerosis. Now that's, taken from folks undergoing surgery, but there are many more links in the clinical literature that show how great a marker these are. I don't know how they're not used or weren't used for these diseases. So I wondered, what about exercise? Actually, my former PhD advisor brought them to my attention, Mike Phillips. And so we started a couple of studies to check them out. So here's our monocyte floating around the blood, one of our leukocytes. Here's a platelet, right? A little cell fragment. And this is a monocyte platelet, or platelet monocyte complex, a monocyte with a platelet stuck to it. Okay? These are very sticky and somewhat activated. Okay? All right, I won't go into detail on the biochemistry, but activated platelets in this inflammatory milieu will express greater P-selectin, which is a receptor on the cell surface which binds to a receptor on the monocyte itself, and that itself will promote activation. So the whole forming of these monocytes is pro-inflammatory. Okay? All right. So that leads us to our first sticky monocyte study. But before I get there, I'm going to show you a couple of slides that highlights the clinical role that these aggregates may play. Quickly, these are data where, let's see, a couple hundred individuals came into the ER experiencing chest pain. Chest pain could be a heart attack, or it could be many other things, gas, indigestion, you pull the muscle, whatever. So they divided them, of course, those who actually were having an acute myocardial infection were placed in one group, and then all the others were in another. So there were 150 without heart attack and 61 with. And they simply measured the platelet monocyte or monocyte platelet aggregates, different names, and there was a clear difference, quite variable, but a clear difference between those who had a heart attack and those who didn't. Those having a heart attack had the greater PMCs, as we call them. Okay, so that's interesting. What's more interesting, actually, is that when anyone comes into the ER with chest pain, they generally do cardiac enzymes and markers in the blood of myocardial muscle damage, your heart. One of them is called CK, CKMB. So what they did here, I'm going to read this and then explain. It shows monocyte platelet aggregates in circulation with respect to initial creatine kinase isoenzyme. So what that means is they divided the folks who, when they first got to the ER, they had their blood drawn, they had their CK levels measured. Some of them showed, yes, high CK, that means they're having a heart attack probably. Many of them did not show a high CK yet. They didn't have a high CK because it can take 4 hours or more for cardiac enzymes to be elevated. However, in those folks who had no elevated CK, their monocyte platelet aggregates were already up there. What does that mean? Well, 57% of the heart attack patients had the normal CK, so we may or may not know that they were actually having a heart attack yet. Could we treat them or not? Therefore, this measure, the PMCs or MPA, appears to be an earlier marker, an earlier indicator of heart attack than other routine markers that have been used for some time. So this is really interesting. I just thought this is the coolest thing ever. So what does exercise do to it? You know, so this is an important marker of disease. We know exercise will reduce incidence of heart attacks. So it looks like PMCs could be an early marker of acute myocardial infarction, and I'm sure there's more work going on there. And very quickly, by the same token, PMCs were measured in healthy controls versus diabetic patients. Here's our diabetic patient, clearly many more PMCs. And these diabetics had no vascular complications, and none of them were on insulin. They were either being treated with diet alone or diet and metformin, a common drug. Now here's a big list of a bunch of numbers. I'm just going to point out a few. First, plasma glucose was much greater in the diabetics than the controls. Of course, we would expect that generally. Here's our hemoglobin A1C. I don't know if they didn't measure it, I don't remember here. But general hemoglobin A1C, if you're healthy, 5 or below, 5.7 or below. Once you start getting 5.7 and up, that's a marker of inadequate blood glucose control over time. So all of these numbers refer to lipids, cholesterol, fats. These, white blood cell number, monocyte number, none of them rather, were different between the groups. Here's CRP. I would expect diabetics to have higher CRP. They did not. It looks like they're trending higher, but the p-value tells us they are not statistically significant. Now you could argue that this group above 3, that's in the high risk category, this group in the moderate risk category. That could be clinically relevant, but statistically they were not different. Finishing up real quick, IL-6, pro-inflammatory hormone, was different. What was the one thing that was different? In these, we'll call them early diabetics. They're not yet on insulin. The platelet monocyte complexes, or monocyte platelet aggregates. They were statistically different, 43.8, 31.2, between groups. So, the elevation of MPA may be an early marker of diabetes, which precedes the other signs of inflammation. So no actual exercise work had been done on these. So we wanted to determine the influence of exercise. So here comes our sticky monocyte studies. Now I'm going to get a little bit technical quickly. Try to follow along. So this is how, it's fun though. Okay, we got this fancy new flow cytometer a year and a half ago, and this is how we measure stuff. We take cells and we tag them with fluorescent markers, and then you run them through the flow cytometer and they glow with whatever color that fluorescent marker is. And we can tell what markers are on the cell. So monocytes express, I'm not going to explain, but CD14 sticks out of monocytes. And generally monocytes are the only cell that has CD14. So if we tag a monocyte with a red glowing molecule and we run it through the cytometer, every cell that goes through there glowing red is a monocyte. Get that? Okay. Other monocytes differentiate into inflammatory monocytes. They have a marker called CD16. So we could tag CD14 with green and CD16 with red. If a cell is just green, it's just a regular or classical monocyte. If it's green and red, we know it's a monocyte, but it's got the CD16, which means it's been activated. See? I did well in coloring. So anyway, this works for me. This is a plot of what our cells might look like. Okay? Watch closely. Oh. CD14, this is green. Alexa F means green. It's not going to show up here. All the dots are red. But Alexa F is a green, glowing fluorochrome. And it's tagged to the CD14. So the cells down here mean they have low or no probably no CD14. We call these negative. And the ones way out here have really high. So going from left to right, the concentration or the expression is higher. So you could say then, everything on the right of this dark white line, all of these cells are monocytes because they're all on the right side of this white line. Similarly, this is CD16, where down here means low or no CD16 expression. This means high. So that means we can divide the top and the bottom. all the cells up here have CD16. None of them here have CD16. So here we are looking at different phenotypes of monocytes. And why do we care? Well, CD16 are pro-inflammatory, classical or not. And we could talk about, that's a whole nother lecture. But so here are our classical. This is a common plot, this common curve. Most of our monocytes in healthy people are generally classical, no CD16. Then the curve goes up, or the plot goes up and curves over. Here's the thing, these are intermediately inflammatory, and these have really spit out, they've been very active. They're non-classical. They have high CD16, but look, low, coming from high to low, lower CD14. It gets confusing, but these are all different important monocyte phenotypes. And you have to, until lately, the current study, we had to kind of do our best estimate where we wanted to put these two different populations. And different authors use different marks or cutoffs. So keep that in mind. So anyway, there's a bunch of words. Okay. So we're glowing, what do we say, red and green? Well, guess what? We need one more color. So we can tell with red and green if it's a resting or classical monocyte or an intermediate or a non-classical. One more marker, CD42A. That is a platelet. So if you have an event, a cell go through the cytometer and it's just green, and let's say this is purple. If it's green and purple, it's a classical monocyte with a platelet stuck to it. Because this marks a platelet and the color we're using there is purple. If it's red, green, and purple, it's one of our inflammatory monocytes and it's got a platelet stuck to it because it's all three colors. So it's really cool how it works. And this is, many of my participants, what are you measuring in our blood? How are you measuring it? Well, this is one of the main topics of study. Okay, so in sticky monocyte study number 1, we just wanted to know, did fitness influence PMCs? Did being physically active reduce your PMC level? It was a cross-sectional study. We had a group of sedentary and a group of fit men and women. And let's see, these numbers refer to maximal oxygen consumption, so they were cutoffs for sedentary and fit to make sure we had a good separation between our fit folks and our sedentary folks. Okay. They were normal body weight, or I guess up to 29 would be somewhat, 25, 29 is slightly overweight. Anyway, we had 40 participants. And here's what we found. First of all, before we even talk about those platelet monocyte complexes, we looked just at these inflammatory monocytes. So see this big red square? We looked at all of those and asked, what is the percentage of all these inflammatory monocytes out of the whole group of monocytes in our sedentary versus our fit individuals? And you can see what we found. The fit individuals had significantly fewer inflammatory monocytes, this in the red, compared to the sedentary. And that was really good news because a colleague of mine had reported that several years previously. They actually examined the same thing to determine if fitness reduces the inflammatory monocytes. So this meant our assay, our experiment is good, and we were glad to see this. Okay? So fitness definitely protects against the formation of inflammatory monocytes. And then, so we used red and green, and then we tacked on the purple and tagged same blood cells with CD42A, purple as I mentioned before, and we just put it on a histogram, and we have a control that tells us the difference between negatives and positives for CD42A. That means, is it a platelet monocyte complex? Do those monocytes have platelets stuck to them? And these are data from one person. Each of these dots, if I wasn't clear, each of those dots is a cell or a cell complex from one person's blood sample, a tiny blood sample. So in this person, it looks like 18%, actually, This is classical. So this histogram was pulled out just looking at this group of cells, so not the inflammatory. And in these cells, it looks like 18% of them had platelets stuck to it. That's how we measure. That's how we get your numbers. That's how we analyze the blood, or whoever's numbers. Okay. So let's look at the PMCs for this study. Okay, looking at all the monocytes, here's what we found. All the monocytes, regardless of the phenotype. Yes, PMCs were greater. The percent was greater, about 17 in sedentary versus about 11 in fit. Okay, a cross-sectional study, the first to examine fitness, the influence of fitness on these platelet monocyte complexes. Now here we start breaking the analyses up into the separate groups. The trend continued. Some of them are statistically different depending on which group. Some of them aren't quite, but you can see in general, sure, fitness appears to have an impact. At least there's some relationship. Again, this was a cross-sectional. We didn't train them up. We brought them in, did some preliminary measures, and got a blood sample. We did notice that C-reactive protein was associated particularly with the PMCs out of the inflammatory monocytes. The relationship R was 0.75, and it was significant, barely. And speaking of barely, I just have to point this out though, we would expect if fitness does play a role in reducing PMCs, it should be related, negatively related, and it just barely was. There was a low relationship, negative, between VO2 max and that same population of PMCs, whereas as your fitness increased, your platelet monocyte complex percentage or count decreased, and that's a good thing. That's a low correlation, and it is significant, but we probably need more people to confirm that. But this was really interesting, and of course led us to our next study. But the summary here, PMC percent and lower in those who are physically fit compared to sedentary. And didn't mention it, but we also learned that PMCs tend to form more readily on classical and intermediate monocytes as compared to non-classical. And there are reasons we think, but for time's sake, I want to move right into sticky monocyte number 2 study. We did the same exact thing as number 1, except this time we pulled in overweight or obese people. Remember our fat or fit population? Yeah, we wanted to try to do the same measures and determine if body weight or body fat played a role. So the physically active reported that they exercised 180 minutes of moderate to high intensity exercise per week for a minimum of 4 months, including aerobic resistance. And sedentary folks reported our cutoff was less than or equal to 1 hour of structured physical activity per week. And I can tell you, I wish we had changed that up a little or made the criteria more stringent. I won't go over this slide, but here, these are our physically active participants, overweight. These are our sedentary. Now you may see what looks like a little trend, but these were not statistically different. These means were similar. Okay? So that's not what we had hypothesized or hoped to find, but when we looked at all of our data, I'll show you something. This is body mass between the sedentary and the physically active. Fat, android. Android fat was different, meaning the amount of fat you carry in your belly, even though the physically active group tended to have a little more fat overall than the sedentary. The sedentary folks had statistically more fat in the belly than did the others. We adjusted for this using a MANOVA. Here's what I really want to show you. The VO2 max measured on the treadmill. For our sedentary folks, it was 27 rounding. Fit, it was 30 rounding. That difference of 3 milliliters per kilogram per minute probably wasn't enough. I don't think we had a good enough separation between the physically active and the inactive. So that would be something, it is something that we're following up on right now in this current study because we are exercise training overweight individuals. A couple of notes though, our hemoglobin A1C was statistically different between the two groups, so even though VO2 max wasn't, there was a metabolic difference between our two groups. And we found that hemoglobin A1C correlated, moderate correlation, with the density of the platelets on those monocytes. Density, as opposed to just percent of total or number, the density. So, interesting finding. I'm going to show you these quickly so you can compare just our data, what it looks like when we compare a physically active person with a hemoglobin A1C of 5.6. There's the monocyte plot. This is our histogram that shows the percent of PMC. So in this physically active person, about 10-11%. That's what we would guess. And a sedentary person, their A1C was actually a little bit lower, but both are healthy. Here's their plot, but look at the percent PMCs they have. 33 versus 10 in a sedentary individual. And then in a diabetic, okay, A1C, of course, is fairly up there. See how most of the monocytes are classical here? Then they start moving up into the inflammatory. Look at the diabetics' inflammatory monocytes. The inflammatory monocytes are 82% here, 24% there, and just 15% there. And of course, the PMCs here measured at 49% compared to 10. Okay? So this diabetic is just for comparison to the physically active and sedentary, and I would love to get a bunch of diabetics and train them up now. Maybe that's in the future. So our current study, finishing up, there's our subject population. Okay, we recruit them as generally sedentary. Our N right now is right in that range. We're doing a 12-week intervention, similar to the LOL study I mentioned. They're exercising 3 days a week. They're doing both resistance and aerobic exercise, rather than just resistance. We're using both. The education group coming in 2 days a week, and I try to give you an idea of some things they do, and we have a pretty good time in there when I get to speak. They have a lot of guest speakers. But we've talked about this study. They've seen some of these slides already. We talk about pharmacology as it relates to them and the meds they're on. Just exercise in general, health. We'll do some stretching from time to time. We've had Susie Lockwood, our new dean, came and spoke on cancer treatment and prevention. Pam, Officer Christian, came and gave a self-defense class last semester. Last semester they also learned CPR. So we're pretty active in that class. Let's see. Now, before and after this 12-week intervention for both groups, we do an experimental trial. That's our big blood draw day. Okay? What? Quick rumbling. Okay. So they come in the morning in a fasted state for supine rest, about 15 to 20 minutes. It depends. We want to get a good resting heart rate and blood pressure. And then the experimental session starts. The exercise group completes an exercise session, which includes 8 resistance exercises at 70 to 80% of their maximum strength, plus 30 minutes of treadmill walking. Now the resistance training includes 2 sets of each of the resistance exercises. The first set is at 8 reps, 2 8 reps. The second set is to failure. Generally, they should fatigue around 8 reps if we're close to the target. They may go a lot more. It depends on how well we measured their 8RM. Hopefully, we're close. Okay, and then after the resistance exercise again, they do 25 minutes of treadmill walking at 65 to 80% of their VO2 max. We want to get them close to the 80 generally for the experimental trial, but once they start the actual training, the 12 weeks, we lower it and let them adapt more slowly based on how they did at the experimental trial. And then finally, we have a 2-hour recovery period. Now during the exercise session, our education group rests quietly in the lab. We obtain blood samples from both groups at all these time points: pre-exercise, post-exercise or post-rest, 1 hour and 2 hours post-rest or post-exercise. I'm not mentioning it in this talk, but we are measuring FMD, flow-mediated dilation. It's a measure, a functional measure of arterial health, and we're doing that before the experimental time period, the exercise or the rest, and then 2 hours after. And certainly we're going to compare our immunological data and all other data to changes, if there are any, in FMD. Again, this whole process occurs once before the 12-week intervention and then once after the 12-week intervention. Okay, so we are measuring the platelet monocyte complexes, as you know. Yep, 5 minutes. Okay, so I wanted to point out that, remember how I mentioned it's really hard to designate these different populations here? Well, Mike, in his literature review, very in-depth, like most graduates should be doing, he found a way to do so. It looked like other authors were using a new marker on the cell surface to differentiate between the intermediate and the non-classical without having to eyeball it. And it's another marker, CD192. So basically what we do is just take these cells, pull them over here, and ask it to tell us which ones have this marker and which ones don't. Because as cells lose their CD14, as they go in this direction and become more inflammatory, they also lose the CD192. So either they have it or they don't. So we know these are our non-classical, hence the blue corresponds to the blue here, and these are the intermediate, hence the green corresponds to the green here. You see what? I just think that's the coolest thing, and one way science is done. So these are no CD192 with CD192. And then here, certainly, you could pick any box and look at the platelets, platelet monocyte complexes. Okay, last couple of slides. So far, we've looked at the acute response to exercise. No one has done this in generally, apparently healthy, maybe overweight, but apparently healthy individuals. And we find that, not shockingly, exercise significantly increases the number of PMCs in circulation. Notice this little fluctuation here in our exercise group. He's listed as con, or in our education group, sorry. You see why it's so important to have a non-exercise group to account for changes, but these are significantly different. So what does that tell us? Well, due to hemodynamic variables, just the movement of the blood, the hypertension, the good hypertension with exercise, increases blood leukocyte number and sometimes platelets as well. So it may be a function of that. But what we're going to be interested in next time, we've measured it out to 2 hours thus far, we would like to look what happens 24 hours later. Because why does this little blip matter? I want you to know that we've for a long time known that consistent exercise improves symptoms of diabetes. It improves insulin sensitivity. And it seemed like it was a chronic training effect until the research was done. And we know now that if you do one exercise bout, if it's hard enough, intense enough, or long enough duration-wise, it will improve your insulin sensitivity for several hours, maybe even the next day. So are these chronic effects, these good effects that we're seeing due to exercise, like for long-term and they last 3 weeks, or are they simply residual effects of the last exercise bout that build up because you exercise 3 times a week, right? If they last 24 hours, you're going to be in that state almost all the time because you're exercising 3 times a week. It's an important point I wanted to raise. Okay, I'm going to skip that slide. It was just for fun. I'm going to mention the T helper 17s. Okay, last bit of data. I haven't got to talk about them much, but it appears that T helper 17 cells are involved in many chemicals are released. They're involved in signaling the brain due to other stimuli to increase blood pressure. And it's due to damage incurred in the body, and these cells are binding to some of our damaged molecules. They're seeing our molecules as a pathogen. They're not me anymore. It's a pathogen. That's why I said autoimmune earlier. So anyway, in our exercise study we're doing now, there was, I believe, a main effect tendency for main effects of exercise. Here's the exercise group: before exercise, after exercise, 1 hour, 2 hour. Here's our common condition, our education did not change. So there was a time effect where the post-exercise time point was lower than the pre, but they couldn't, the stat did not differentiate between the groups. This black line is the mean where the time main effect occurred, but clearly that's driven by the exercise group. So we'll have lots more data on our T-helper soon. We did run a little regression on our baseline numbers, and we determined that there were a couple of variables we measured that explained the total number of T-helper 17 present. Number one, your hemoglobin A1C, how well do you control your blood glucose? The hemoglobin A1C variable numbers explained 20% of the variance in T lymphocyte number among participants. Also, our treadmill test, the results, our absolute VO2, our maximum VO2, your fitness, explained 12% of the variance in T-helper 17. Blood glucose control and fitness. So these need to be further explored, these findings, but I thought they were interesting to show you today. So I thank you. It takes a lot of people to do this kind of longitudinal training study, and these are just a few of them. Thank you for your time today and your attention, and I appreciate you.
I know we're out of time. If you want to stay and ask questions, you can. If you need to leave, feel free to go ahead and do so. There's probably more food out there. Take it with you. But at this point, any questions? Ask for stuff.
Yes, ma'am.
Do we get, but for ourselves that are in the group, do we get a report about ourselves?
Yes. Yes, for most data.
If you were part of a group.
If you were to be part of a group, not saying that you are. Yes. Yes, exactly.
I'm saying that you are.
Hypothetically. This is great.
Right. Because this is stabilized state. Yeah, but all these nurses. That's why. Yeah. I was hoping we were going to get her. They would be available too.